Hello, I'm Dr. Hercumel Kara. I'm a board-certified urologist at NorthBay Healthcare. For the next half hour, I will be answering your questions on urologic health issues. I did my undergraduate degree at the University of California at Berkeley. I did my medical school at the University of Southern California, and then residency training in urology and general surgery at the University of Michigan with fellowship training in robotic surgery. With me, off camera, is Robin Miller, a member of the NorthBay Healthcare PR team who will be reading your questions to me.
Well, thank you for doing this, Dr. Kara. I appreciate it. We're just going to get right into this. You've been making the rounds recently talking about a procedure called UroLift. And this is to deal with a medical issue in men called BPH. Let's start by having you explain to us what is BPH, what are the signs, and...
Sure. So BPH is short for benign prostatic hyperplasia. Essentially, it translates into a big prostate. A prostate's a gland that men have. It sits below the bladder, and a man voids through the middle of the prostate, so the urethra travels through this. Women don't have this organ. It's a reproductive organ, and it serves a function during the ages of reproduction, but after the age of about 40 or 50, oftentimes it can cause troubles. Classically, there's 2 or 3 problems that can develop. One is prostate cancer, one is BPH, an enlargement of the prostate, and one is prostatitis. Specifically, BPH is when the benign areas of the prostate grow and they squish on the urinary stream. Some analogies I like to use is imagine stepping on a hose. It reduces the flow within the urethra, it prevents the bladder from emptying effectively, and oftentimes makes men have to go to the bathroom a lot more frequently than they normally would.
How do you know that it's BPH and not some other problem?
So that needs a medical investigation. So the question was, how do we know that this is BPH and not another problem? That needs a medical investigation, generally with your primary doctor and or your urologist. There's a series of different things that can be checked, including blood and urine testing, physical examination, and also going over a detailed history. Sometimes imaging is used, such as ultrasounds. There's a variety of different things that can be done, but it's important at the very least for any patient who's having urinary symptoms or prostatic symptoms that they think is coming from their prostate to get investigated and see their doctor.
So how is the UroLift different from, say, other traditional treatment options?
Sure. So the question about how is the UroLift different from other treatments. The traditional therapy that dates back over 100 years for treatment of the prostate was the transurethral resection of the prostate, almost like the roto-rooter surgery, a lot of people would call it. And it involved putting a scope in through the urethra and resecting that obstructing tissue. This was an effective therapy, and it's been modified over the decades to be more effective with less risks and complications, but it still was a surgical intervention with potential serious risks. There would also be side effects from this therapy that could include effects on sexual function, erectile function, and rarely some problems with urinary incontinence. Now, the UroLift procedure, unlike the transurethral resection of the prostate, and I call that the TURP, the UroLift procedure approaches this differently. Instead of resecting or destroying the tissue is essentially pushed aside. Lots of different analogies to describe this. You can imagine the rope that you use to pull back a curtain and pulling to the side to let the window open. Same general idea. Here's like an image kind of giving you an idea of the prostate that's obstructed. Can you see this, Robin? And so this is imagining an obstructed prostate with the urethra completely blocked. By placing the UroLift devices, that spongy prostate tissue is essentially pulled out of the obstruction, creating an open channel for the bladder through the urethra. Really effective. And what's the difference between this and the old treatments? Well, the old treatments with their resection or destruction of the tissue, like I said, risked more side effects. As this is done without destroying any tissue, the side effect profile is low and the recovery rate is very quick.
So is UroLift good for everybody, or are there certain things you're looking for that make a good candidate?
Of course. So not all therapies fit all different patients. What we're finding is a lot of men who are, let's say, on pills for their prostatic problem, taking things like an alpha blocker, generically known as tamsulosin, or other medicines like dutasteride. Sometimes they're having a lot of side effects from that therapy. They might be getting some degree of relief of their symptoms. Maybe they're going from getting up 4 times at night down to 2. Maybe they can wait 2 hours before having to empty their bathroom instead of empty their bladder in the bathroom, as opposed to every hour. But oftentimes that's not enough relief. Oftentimes there can be side effects of these therapies. The classic thing with the alpha blockers are sexual dysfunction and sometimes getting dizzy from getting up too quickly. These are serious risks. With the other class of medicines like dutasteride, you can get things like breast enlargement or decreased libido. There's a small risk of high-grade prostate cancer with those medicines. So patients that are on these medicines that want to get off of them oftentimes do really well with the UroLift procedure. Like I said, is it for everyone? Absolutely not. There needs to be an evaluation to determine that there is this degree of obstruction as we discussed. But it's a pretty common problem, and the UroLift can help the vast majority of men with big prostate.
Great. This is good information, and I want to remind the people who are following us on Facebook Live that if you have a question, just type it in. We'll be able to see your questions as they appear on screen, and we can pass it on to the doctor and have him answer it. I want to move on to another subject that's in your area of treatment. You have another couple of talks coming up about urinary incontinence. Sure. And I wanted to talk to you a little bit about that. Like, what are the symptoms and what are the different types and causes?
So this is our Laugh Out Loud seminars that are going to be next week. So urinary incontinence has a variety of different causes. I think for the purposes of those talks, we're focusing more on female incontinence. And in those circumstances, there's generally two ways that the incontinence manifests. One is the stress incontinence. And stress incontinence classically is with a cough or a sneeze or positional change, losing some urine. That can sometimes develop after childbirth, after prior surgeries, or just with the normal aging process. The other class of incontinence is typically urgency, and that's more of an instability in the bladder. The question I usually ask patients is, you get the urge to get to the bathroom, and before you get there, do you end up leaking? That's a good example of urge incontinence. Sometimes people have a combination of the two, but it's important for us to determine, what is the underlying process, because the treatments are different. We have a variety of different treatments, and to kind of start talking about that would probably take us the whole length of our discussion, and we'll have the seminar next week. But it does give some perspective that not all incontinence is the same.
How do you diagnose this? Is it just the patient tells you this is what's happening to me, or are there tests? Or?
So part of being a physician and being a urologist is a little bit of detective work and trying to figure out these specific situations when the leakage is taking place. So a lot of questions, but there is also an examination that helps us understand the anatomy. And we have a multitude of different tests that we can do in the office to get a better understanding of the bladder and how the bladder is functioning. Some examples would be putting a little scope into the bladder. There's another neuromuscular test that we use on the bladder called urodynamics, and that oftentimes allows us to discern what is the nature of the incontinence and how the bladder is functioning.
We have a question on UroLift. Is this a surgery or a procedure, and does it require a hospital stay?
So the UroLift procedure can be done in a variety of different settings. It can be done in the office setting with just a little oral medicine for relaxing and some local anesthesia in the urethra for the anesthetic effect. And now, typically we think of a procedure that's done in the office as a procedure, not a surgical intervention. Now, on the other hand, the UroLift could also be done with more anesthesia, either a light one where people are relaxed, getting it through an IV, or even going to sleep or getting a spinal anesthetic. Those procedures would obviously need to be done in a hospital or surgery center setting. So that it's the same procedure, but the setting can be different.
Okay. And does it require you to take a particular amount of time off from work? And do you know if insurance covers it?
So the vast majority of insurances are in fact covering this, including Medicare and the local Medi-Cal and a few other major providers. It is a procedure that typically afterwards you want to take a few days off of work if you have something that's strenuous. You'll have a little bit of blood in the urine and a little bit of what we call urgency. So when you get the urge to go to the bathroom, you'll want to get there quickly. And that typically resolves within a week or two. In terms of having pain and a lot of discomfort and needing pain medications, that's incredibly rare. Most people have none of those issues or complaints. Recovery is pretty quick.
So as a urologist, you deal with anything having to do with the urologic system, from kidneys to bladders to kidney disorders and cancers and so you probably see a lot of people with kidney stones.
Of course.
I'm assuming.
Yeah.
Explain to us what a kidney stone is, how they're formed, and what you do about them.
So kidney stones are literally what they're called. They're stones made out of different substances. Sometimes they're made out of different amalgams of calcium with things like phosphate or oxalate. Calcium phosphate is actually bone, so it's something as hard as bone. Other things can form it too, like uric acid, and there's lots of other basic mineral type events that can take place within the urinary system of the kidney. And these little stones can then subsequently plug up the kidney. So a patient can have a kidney stone and not even know it. It could be sitting in their kidney and be a half an inch in size for a decade and never even know it's there. It's when it makes that event to move and try to drain out of the kidney. And if you imagine the kidney is somewhat of a funnel and the tube that connects the kidney to the bladder is very fine like a straw, at that straw point is where the stone can get obstructed. Well, the kidney doesn't know what's going on, and it's got its job just to keep filtering blood and making urine, and all of a sudden it's making urine, but that urine has nowhere to go. So the kidney can balloon up, and that's that horrific pain that some people liken to be worse than childbirth. And it can be quite severe. The stone can, depending on its size, pass over time. Sometimes we need to get involved to help it pass or destroy the stone or break it into smaller pieces.
So there are different types of kidney stones, and does understanding the different type help you to avoid them in the future?
Oh, absolutely. So certainly there is a risk of getting kidney stones, let's say just from dehydration and certain things in our diet. But then there's also populations of people who have a real risk for it. And once they get one, they may get another and another. So by getting the stone and then doing some analysis on it, we can get an idea of different things to change in the diet. The classic thing that we're always recommending, independent of what kind of stone that a person's forming, is to increase fluid intake to about 8 to 10 glasses minimum a day of water.
I was going to say water, or do other things count?
Well, certainly alcoholic beverages and coffee and whatnot and sodas are probably a little bit more counterproductive. Notably, some of those drinks have some of the components of stone, and it can worsen the concentration of those things in the urine.
All right, we have a Facebook visitor who writes that he never sleeps more than 45 minutes a night without having to urinate. Should he see a doctor, and is this a danger sign?
So the question, if a lot of nocturia is getting up and going to the bathroom or at night is a danger sign. If this is something new, if this is not a lifelong event, if it's not been going on since you were a child, it should get investigated. It means that when your brain is kind of reducing some inhibition on your bladder's having a hard time just keeping the urine at bay. It feels that there's a reason to get it out. And there's lots of different reasons this could be going on. Classically, if the bladder's not emptying well enough, then it's going to fill up a lot quicker. The analogy of, let's say, a cup, which is your bladder, and you pour half of it out, well, the cup's going to fill up very quickly, and then you're going to have to keep on doing that process. So yes, definitely every 45 minutes is a reason to get checked out.
Is it a warning? Can it be a warning sign of something more serious than just not emptying well enough?
Well,
I mean,
the warning sign of not emptying well next can translate into bladder failure. And then bladder failure can oftentimes translate into kidney failure, which can be a life-threatening event. In addition, not emptying well can lead to getting bladder stones, urine infections, and these infections can be pretty dangerous because they're coupled with the infection not being able to get out of the body because of whatever reason.
What strategies or treatments can help with enlarged prostate? I mean, beyond having a UroLift procedure.
So we don't have necessarily absolute lifestyle changes that will change the anatomy of the prostate. We do find that general prostate health is benefited by a low-fat, lean protein diet. This is more tied to populations of people as opposed to this individual went on this diet and suddenly his prostate got better. But that can also be translated to a probable decreased risk of prostate cancer in populations as well. There's been some investigation into using mass doses certain vitamins and minerals, selenium and zinc. Most of that data has been actually to the negative, meaning it's been more of a harm to patients. So we're pretty firm in our recommendation not to take mass doses of any of these supplements. That can most likely cause more trouble than good.
Speaking of prostates, you deal with a lot of prostate cancer cases. There's been a lot of studies out recently about how common that is and how maybe initially it doesn't require a lot of treatment, that it's normal to appear. Tell me a little bit about prostate cancer and when do we treat it and when do we say, let's see what's going on here.
Sure.
And how do you diagnose it?
Prostate cancer at this point is the most commonly diagnosed cancer of men in America, and it's still, with everything that we're doing, the second leading cause of cancer death for men in America. Previous to the late 1980s, our only ways to really diagnose prostate cancer early or detect it would be based on a rectal examination and finding something nodular and hard and then subsequently doing a biopsy. Our concern, problems, issues back then used to be 30 to 40% of these patients had already progressed to a stage that couldn't be cured. So around that time, we use that as a marker because a blood test was found to be effective in trying to screen for prostate cancer. It's called PSA, prostate-specific antigen. And with this test, we were able to start catching people earlier who had prostate cancer before they had nodular involvement of the prostate. But these remain our two kind of main tests in terms of screening for the disease. There was a bit of a backlash because the PSA allowed us to catch a lot of cancers, and sometimes those cancers, we've later learned, were not as aggressive as anticipated. Without actually diagnosing the disease, it's hard to know if someone has an aggressive or non-aggressive cancer. So once there is suspicion based on the rectal exam and history and the PSA, if a prostate biopsy is done, which is an outpatient procedure in an office setting with just local anesthetic, if there's cancer, the decision is how to investigate this further, determine if it's an aggressive phenotype, meaning it has a high likelihood of progressing, versus the possibility that it can be put on what we call active surveillance. And active surveillance essentially entails monitoring the disease, and if it starts showing aggressive characteristics, then progressing on to treatment with curative intent. So active surveillance is not saying we're not going to treat this disease for whatever reason. We're going to treat it when it shows that it's aggressive. And there's a nice thing about prostate cancers. The vast majority that we detect, we have a big lead time. That means a time before it's going to start causing problems. And in the process of active surveillance, we almost never lose the curability window. The benefit is many patients are spared the need for a big radical therapy if they're kept on active surveillance.
Now, we've been talking a lot about prostate issues and male issues. How about let's talk about the women and some of the issues you see that are common in your practice with women patients?
Sure. We talked about kidney stones and urinary incontinence. Those are probably the two main things that we see from our practice. We also see a fair amount of recurrent urinary tract infections, and that can also increase with age. There's a variety of different reasons that one can get a recurrent urinary tract infection. Sometimes there's foreign bodies within the urinary system which are just seeding the system with infection. Antibiotics are taken, the infection is cleared, but then the foreign body, like a stone, sends bacteria out and we get recurrences. So there's a good reason for investigation of that. Also part of the aging process for women, there can be issues with estrogen changes and bacterial overgrowth within the vagina, and that can lead to recurrent infections as well. Some of our solutions for this are pretty innocuous, like vaginal estrogens when safe. And they can have a profound impact in reducing the incidence of these infections.
Okay. And your Laugh Out Loud conversations that are scheduled for June 20th and 22nd, tell us a little bit about what you'll be talking about there.
Both myself and our pelvic floor physical therapists will be talking about what is good bladder health, what are our techniques for dealing with urinary incontinence, or early urinary symptoms like urgency and frequency. We can talk about the anatomy, the impact of diet, medications, and the role of surgery in the treatment of these problems.
What one health tip could you give men and women to keep good urinary tract, urologic health?
One single health tip for everybody. As we've been talking about all these different classes of urinary health, like kidney stones, bladder infections, big prostate cancer, some of the circumstances are different. Oftentimes good hydration is our best approach, lots of water, but there's always a balancing act. So, that's why I want to say this with a caveat, because certainly for patients with benign prostatic hyperplasia, the BPH, who's getting up every 45 minutes at night, that's not feasible to say, keep drinking lots of water. You'll be exhausted if you're getting up that much. So sometimes in those circumstances, we fluid restrict at different times of the day and rely upon the thirst mechanism. But in general, for most of these disease processes like infection and stones, it's really beneficial to have good hydration and keeping the system just flowing and flushing out the waste.
What about salt intake?
Salt is bad all around. There's so many disease processes that are that benefit from people eating too much salt, and it's one of the factors of our Western diet. Certainly, I think the number one culprit from the urologic world is kidney stones. Being on a smart sodium intake diet, generally less than 2 grams a day, can dramatically reduce the incidence of recurrent kidney stones. So we counsel our patients with kidney stones most definitely to focus on sodium reduction.
All right. Well, I think I don't see any other questions coming in, and we're just about to the end of this chat. Anything else you can talk to us about urology, what you do here at NorthBay?
Oh, I can talk to no end about urology.
Anything else you think our listeners should be hearing?
I think it's important. Over the course of the last few months, I've been giving some community health talks, and the thing that's been really striking me in this process is so many people saying, "Well, I just thought that this was the normal consequence of aging." So many people have told me I've had this problem for 5 years or 10 years, and even after treatment, they're just blown away by the impact it had on their life. I hear very often, I wish I had just come in sooner. So people that are suffering from urinary problems or things are not working as well as they would like, it would be really beneficial just to get checked out. Just letting your doctor, your primary doctor know, or giving us a call, or your other urologist, to say, I'm having these issues, and is there anything that can be done for this? Because there's lots of new technological changes, and the field is pretty cutting edge in terms of treatment of disease.
All right. Well, thank you very much for taking time out of your schedule for this. We appreciate it. This video will live on our Facebook page, and you can also find it at northbay.org, where you can also find more information about Dr. Kara and his office. So check it out. Thanks.
Thanks, Rob.